Okay, welcome back to the Independent Doctors of Pahrump television series. I'm here with Dr. Savran, and I'm Dr. Michael Reiner, and this is Dr. Steve Savran, a cardiologist in town. I'm a independent family practitioner. And we're here to kind of continue a series of really don't have a particular topic, but last time I was talking about the low amylose diet, or basically low carbohydrate diet. And since you're here, I think it would be good to kind of continue that to get your perspective on from a cardiologist about the low carbohydrate diet. And one of the topics that you and I had both discussed was this idea behind, or at least my belief is that controlling sugars and controlling diabetes is one of these things that's even, I think, more important than the actual cholesterol. And you and I had this discussion because as a cardiologist, you have these guidelines that you set for people with heart disease, and correct me if I'm wrong, but the idea if you've had heart disease of any type, whether it be a stent or a heart attack, an event, it makes you a different patient than trying to prevent heart disease. And therefore, the LDL that you strive for is usually less than 70 on that particular number. Is that correct?
That's correct.
Okay. And if you're trying to prevent heart disease, you're trying to achieve an LDL or a bad cholesterol of less than 100.
That's correct.
That's correct. So that's the number at least I strive for in my practice, and I know you strive for. So the discussion came about, which is the analogy which I used, which you actually like, was that if I took two individuals and I had both of their cholesterol particles in a hand here, and one had diabetes and one didn't. The numbers were the same, meaning if you drew their blood, you had 150 total cholesterol, an LDL of 105, and you had an HDL of 38. On paper, it looked the same, but that diabetic had a much smaller particle cholesterol. So the analogy was if you had a door and you were to roll their cholesterol particles like marbles at the door, the one that had the diabetes, most of their cholesterol particles would go under the door, meaning the analogy would mean they would go into the cell of the arterial wall, okay, where they can be oxidized by oxygen and cause more of damage to the cell wall. Thus enhance why diabetics have, I don't know, fourfold increase of heart disease over the non-diabetic model, right?
When we look at cholesterol, what we're looking at is a number.
Right.
And if someone's cholesterol was 300 or 100, they're going to feel the same.
Correct.
So what we're looking at is statistics, and the statistics are actually very, very simple. We assign a number one, to each cardiovascular risk factor. Cigarette smoking, high blood pressure, family history of early heart disease in the 40s in men, 50s in women, and then we assign a number to the LDL. And the number that we assign to the LDL varies on the patient, and we simply add up those numbers. A high level of good cholesterol of HDL is a negative risk factor.
Right, but it has to be greater than 75,
It has to be greater than 60. It has to be greater than 60.
Okay, so the Framingham study was 75.
Right.
But they lowered that down to 60.
The guidelines are 60 now.
Okay.
And what we do is we just add up risk factors. If you're a smoker with a positive family history and high blood pressure, you bought yourself 3 points. And then knowing what the chance is of having an event in the next 10 years varies with the number of points. 3 points or more, there's better than a 20% chance of having an event in the next decade.
Okay.
We define an event as a stroke, a heart attack, needing me to perform some of the stuff that I do, angioplasties, or sudden death, which sort of ends the whole risk factor right there in those patients.
Very much so.
Someone with 1 to 2 is at 10 to 20%, and someone who's 0 is less than 10%. However, the diabetics are different.
Right.
The statistics with diabetics are different because now we're only looking at a chance of someone who's never had anything happen to them have something happen for the first time. The diabetic is considered the equivalent of someone who's already had an event.
Oh, okay.
So the diabetic's next door neighbor, who just got out of the hospital after a heart attack, had a stent or a bypass and is doing fine. You look at his future. the diabetic carries with them statistically the same future as that person that's already had an event. So we treat diabetics as very high risk.
Okay.
And that's where, as Dr. Reiner said, that's where the different numbers come in. We have different goals for different numbers. The people who are at low risk, medium risk, we try to get the LDL at 100, and the LDL is the big number that we look at.
Right.
If someone's had an event or is a diabetic, we try to get them down to 70 or so.
Right. And even within those numbers, like I see diabetics, and a lot of times in my practice, I'll have patients, we aggressively talk about their cholesterol, as I'm sure you do too, and we aggressively, we try to get those numbers down in that range. But I still believe that if I have a diabetic whose LDL is 72, 71, and their total cholesterol is 150, and on paper it looks good, their average blood sugar is not doing well, I'm still concerned about that, because that still spins off small particle disease.
It does.
And so what I'm trying to say is and again, that gets back to the square one, which is those people are certainly more likely to have heart disease, and until you get them to control their diabetes, they really don't mitigate all their risk factors.
No, they don't.
Right.
My biggest goal with adult onset diabetics is to have the patient get rid of their diabetes.
Correct.
Because diabetes in most adults who are not taking insulin is curable is a little strong word, but certainly one can get off diabetic medications.
Correct.
One can have all of their lab testing show they don't have diabetes, and at that point they fall into a much lower risk group, and that's where the diet comes in, the low carbohydrate diet. The statins, the drugs that we use, lovastatin, rosuvastatin, simvastatin, all of the statins, are absolutely marvelous drugs.
Correctors, yes. It's just, can you keep the numbers in that same level, right?
Yeah, the differences are so small that basically we're looking at, to kind of go on that one, we're looking at two statins that hydrophilic means dissolve in water.
Correct.
Lipophilic means dissolve in fat.
Fat.
And the two hydrophilic statins are pravastatin, Pravachol,
Correct.
which is an old drug, a good drug, and Lipitor, atorvastatin.
No, Crestor, right?
No,
Travis?
Lipitor is hydrophilic.
Hydrophilic.
Yeah.
I thought it was lipophilic.
And we'll check that out.
Okay.
The cardiologist may be wrong for the first time.
No, that's
this year.
okay. That's okay.
But there's a huge difference in potency.
Correct.
And of course, a lot of what drives us too is the cost of the drugs. Lipitor is now generic, but it's still not as cheap as the other drugs,
Correct.
even though it's generic. To me, the best way to control diabetes is with diet and exercise. There's no question.
I couldn't agree with you more. And obviously, the changes that are taking place with regards to diabetes, with the number of medications that are out there, almost is like, the oral. Well, and that gets into the whole gamut of diabetes, which is, now they talk about using, this drug for this, using Invokana, which helps you excrete more sugar out of your kidneys. So you're touching the diabetes here. You're touching it with the inhibitors with regard to insulin resistance, and you're using metformin. You're using 5 or 6 drugs in small doses to affect the adult diabetic. When it's just changing your diet. And that gets back to square one, which is that low amylose diet, which I talked about, amylose being a compacted starch, but it's not just amylose, it's every starch. It's just every starch that's out there, whether it be bread, whether it be, we're just overwhelmed with starch. And
question for you from a Facebooker. They want to know, is blood pressure related to high cholesterol or vice versa?
Neither. Blood pressure is independent.
Yeah, but it is related. I think it has a lot to do with diabetes and weight gain. So, you can clearly see that as people gain weight, their blood pressure goes up. And aging, there's also the aging phenomenon. There's what is a known phenomenon. It's called isolated systolic hypertension, which is just about, we'll discuss it after the break, but as you get older, your vessels become stiffer, and as they become stiffer, then what that means is you have to get the same blood volume through a smaller pipe. So therefore, you have to increase the velocity to the cubed of that, which causes a real increase in pressure, which is why you see these gigantic, shifts in blood pressure. And I always tell patients, which would you rather be, on a beach getting hit by a 60-foot wave or being hit by a 20-foot wave?
That's a good analogy.
Yeah.
I'd like to talk about that after the break,
Okay.
because a lot of patients have a lot of misconceptions about blood pressure. But again, the most important thing in patients who have diabetes with or without heart disease is the diet.
Yeah, is the diet. So we're going to go to break, and we'll be back in a few minutes. Thank you for paying attention.